today I'll be talking about application of TE for non-congenital heart diseases. So traditionally in pediatrics, echocardiography has focused mainly on congenital heart diseases. However, the role of TE in children is rapidly expanding in non-congenital conditions. TE provides high resolution, real-time imaging and becomes especially valuable when transthoracic windows are suboptimal, which is very common in ventilated or post-operative children. In the perioperative and ICU setting, TE is not just diagnostic, it actively guides management decisions and improves procedural safety. Some unique considerations in pediatric patient when it comes to TE. First, the cardiac structures are very small and it requires high spatial resolution and careful probe selection. And pediatric hemodynamics are highly preload sensitive and can change very rapidly. And interpretation must always be age appropriate because normal values differ significantly from adults. And despite these changes, transesophageal echocardiography offers major advantages, particularly superior visualization of posterior structures and it also gives an excellent utility in mechanically ventilated patients. So coming to the first non-congenital topic, I'll be discussing about heart transplant. So the heart transplant remains the definitive therapy for end-stage heart disease in children. The major indication includes advanced cardiomyopathies, complex congenital heart diseases not amendable to repair or retransplantation. While transthoracic echo is primary modality for follow-up, TE becomes particularly valuable in the intraoperative and early postoperative periods. So intraoperative TE before implantation, when we should do and why. So it usually pre-implant TE is not mandatory in every transplant, but in the right patient it gives us a powerful hemodynamic roadmap before we go on bypass. This allows targeted correction before going on bypass. So the key indications when we are supposed to do preoperative intraoperative TE before implantation is any unexplained hemodynamic instability, when there is escalating inotrope requirements, when there is complex or uncertain cardiac anatomy and suspected venous return abnormalities, and also assessment of pulmonary hypertension and RV status, because assessment of RV status predicts the risk of early post-transplant RV failure. So there are two main surgical techniques, biatrial and bicaval. In bicaval technique, the SPC and IVC are anastomosed separately, which preserves the right atrial geometry and reduces right atrial dilatation. In contrast, the biatrial technique retains native atrial tissue and creates a left atrial cuff. Because of this, left atrium often appears distorted, producing classic hourglass appearance. After transplant, we'll have to evaluate the graft function, the anastomotic sites, the valves, the residual problems. For graft function, we'll have to evaluate the LV and RV systolic function, if there is any regional wall motion abnormalities, and also we should assess the status of interventricular septum. And anastomotic sites, the SVC, IVC, the left atrial anastomosis, the pulmonary artery anastomosis, the aortic anastomosis should be evaluated thoroughly, and it should be evaluated like if there is any turbulence, if there is any flow acceleration, all these must be evaluated and notified. And also the valves, the aortic, tricuspid, mitral, and all the valves should be evaluated thoroughly. And if the residual problems, like if there is any atrial shunting, if there is any intracardiac thrombus, if there is any air, all these must be evaluated. And all these things can give a hint about early post-transplant complications, which includes the primary graft dysfunction, RV failure, anastomotic obstruction, pericardial effusion, intracardiac thrombus, and acute graft rejection. So another important thing is what this LA cuff. The LA cuff, the surgical anastomosis between the donor and recipient left atrium, produces a linear echogenic ridge. it often mimics thrombus. It must actually not mistaken as thrombus. So it can also be mistaken for suture line vegetation, supravalvular membrane, and LA mass. So this image is midesophageal four-chamber view in post-heart transplantation. As you can see, the anastomosis of donor left atrium to the cuff of recipient left atrium creates an area of echogenicity that can be mistaken for a thrombus. Next topic we'll be seeing is the mechanical circulatory devices. Nowadays it is increasingly used for advanced cardiac failure in infants and children. The mechanical circulatory devices provides a bridge to transplant, recovery, or destination therapy. So indications of in children actually differs from adults. It is most commonly used in congenital heart diseases and cardiomyopathy in children. And device selection depends on the patient size, anatomy, and the indication. And both pulsatile and continuous flow devices are available. Berlin Heart XCOR is the most established long-term pediatric pulsatile ventricular assist device. And durable continuous devices, HVAD, HeartMate, can be used in larger children. And temporary VADs are increasingly used as an alternative to ECMO. And TE is essential before and during and after implantation. The role of TE in pre-implantation period is to confirm the indication and severity of ventricular failure, to exclude intracardiac thrombus. There are areas which predispose for intracardiac thrombus, which are LV apex, left atrium, and left atrial appendages. These areas must be thoroughly evaluated, and also there should be a comprehensive RV function assessment. It is actually the RV function is a major predictor of LVAD success, and we should evaluate the LV size, geometry, and also the suitability of inflow cannula. And we should assess all valves, and we should look for any aortic regurgitation, mitral regurgitation, tricuspid regurgitation, and if there is any intracardiac shunts, PFO, VSD, ASD should also be evaluated. And also we should assess the septal position and ventricular interdependence, and we should evaluate if there is any pericardial effusion or tamponade. And we should document baseline chamber dimensions for pre-implant comparison. And this is the image showing transgastric mid-papillary short axis view in a child undergoing preoperative TE during LVAD implantation. So as you can see, the LV is severely dilated and thinned out, consistent with dilated cardiomyopathy and end-stage cardiac disease. So next, the role of TE during intraoperative implantation is to guide the cannula positioning. Ideally, the inflow cannula should be from LV apex should be directed towards the mitral valve inflow, and we should ensure that inlet is free from wall, septal, or any caudal obstruction. We should confirm the outflow graft orientation, and there should be a laminar flow into the aorta, and we should assess the adequacy of LV decompression after the device starts. And also we should monitor the septal shift, and there should not be any excessive leftward shift which indicates RV failure. And also it is important to detect any air embolism during de-airing phases, and to identify any new valvular dysfunction after implantation. And also positioning, also like to assess the positioning of our temporary devices like Impella, and to evaluate immediate RV response after LVAD initiation. So persistent LV dilatation despite LVAD, we should suspect any device malposition or RV failure. So this is a midesophageal LV long axis view showing an post-implantation of LVAD. And post-implantation of LVAD, we are supposed to reassess the LV and RV size and systolic function. We are supposed to evaluate the aortic valve opening pattern, and also detect any worsening AR or TR. And we are supposed to confirm the septal position and assess the inflow cannula for any obstruction, suction events, or any thrombus. And we are supposed to evaluate the outflow graft graft, and if there is any turbulence, we are supposed to rule out any obstruction and screen for pericardial effusion or tamponade, and detect any intracardiac shunting causing desaturation. And we should it also helps in guiding the optimization of device settings when low flow is suspected. This is the same image which I have shown in previous slide. This is the color Doppler showing the inflow from inflow to the LV apex. So this is another image of LVAD post implantation, mid-esophageal aortic valve long axis view, showing the outflow cannula and showing the laminar flow into the ascending aorta. So next comes ECMO. So role of TE in ECMO. TE is often limited, so transthoracic echo is often limited post-op or in ventilated infants. Pediatric patients also have a small preload sensitive ventricle, and complex congenital heart disease and shunt physiology are very common, and cannula malposition is frequent, and there is flow limiting. So, and VA ECMO predisposes to LV distension and aortic root stasis. So TE enables real-time bedside assessment and helps in decision making in unstable patients, and it also helps to distinguish between cardiac failure and circuit problems. So echo is central to safe initiation and surveillance of ECMO in pediatrics. So pre-ECMO TE assessment, we should assess the ventricular function, we should ventricular size and the loading conditions, and RV function should be assessed, and ventricular dependence and septal position should be assessed, and also any regional wall motion abnormalities if present should be assessed. And we should quantify the AR, and we should also quantify MR, TR severity, and we should evaluate pulmonary valve if it is relevant. And shunt assessment is very important in children, and we should assess ASD, PFO or VSD, and if there is any presence, the direction of shunt, and if there is any residual post-operative shunt, if there is a need for atrial decompression, and also we should exclude the intracardiac thrombus, tamponade, effusion, and pulmonary venous obstruction and LVOT obstruction. So TE provides useful help in cannulation guidance, and ideally the venous cannula should be located in mid right atrium. The tip should be located in mid right atrium, and it should not be in hepatic vein or SVC. It should be away from atrial wall septum, and there should be unobstructed tricuspid inflow, and there should be adequate drainage without suction. And if there is any poor flow, RA collapse or suction chatter, and there is some, it gives an hint that there is something wrong with the position of cannula. This image is mid-esophageal bicaval view, and it displays the SPC cannula advanced from the IJV, and as you can see, the tip is located in mid-right atrium. And the second image shows shows after applying the color Doppler. So next, arterial cannula. It should be it can be positioned in ascending aorta arch. There should be laminar forward color flow. There should not be any aortic dissection. There should not be any coronary ostial compromise, and there should not be any arch vessel obstruction. This is another important thing in VV ECMO, dual lumen cannula. Jet should be directed towards the tricuspid valve, and there should be clear separation of inflow and outflow return streams, and there should be minimal recirculation, and there should be adequate RV filling. As you can see, the jet is directed towards the tricuspid valve. So after the post cannulation, we should be assessing the reduction in LV size. This is particularly important in VA ECMO, and adequacy of RV unloading, aortic valve opening pattern, and the septal position, and cannula obstruction or any suction events must be evaluated, and also intracardiac air, pericardial effusion or tamponade should be evaluated. TE also provides an important aid in weaning from ECMO. So so it is important in assessing the patients who are candidates for weaning. So ideally the systolic function LV should improve, should be around 35 to 40%. There should not be any severe regional wall motion abnormality, and aortic valve opening should be consistent in every beat, and LVOT PTI should be greater than 10 to 12 centimeter, and pulsatile arterial waveform should be present, and there should not be any progressive LV dilatation, and LV cavity should be maintained during flow reduction, and there should not be any spontaneous echo contrast in LV. And also for right ventricular function, the size should be normal or mildly dilated, and that it should be free from RV wall motion abnormalities, and the fractional area change should be 30 to 35, and TAPSE should be improving. There should not be any severe TR, and there should not be septal shift towards RLV during trial of weaning. And some common failure signs are LV dilatation, loss of aortic valve opening, RV deterioration, hypertension, and rising filling pressures. All these indicates that the weaning is getting failed. So next topic comes aortic dissection. So it's a rare entity in children. Etiology differs from adults. Usually in pediatric patient, it is due to genetic aortopathies or congenital heart disease and not hypertension. And in pediatrics, the aortic dissection has strong association with connective tissue disorders like Marfan, Loidites, Ehlers-Danlos, and frequently related to congenital heart disease or prior cardiac surgery and any prior cardiac surgery and cannulation. Pediatric aorta is typically non-atherosclerotic and more elastic, and aortic ascending aorta and root involvement is more predominant in children, and clinical presentation is very atypical and less dramatic, requiring eye suspicion. The imaging principle in TE are same as adults, but smaller anatomy depends meticulous multiplane TE imaging. So TE features suggesting aortic dissection are mobile linear intimal flap within aorta, and division into through and false lumen, and flap motion can be synchronous with cardiac cycle. It may demonstrate entry and re-entry tears. False lumen may show sec or thrombus, and we are supposed to confirm this in multiple orthogonal plates, because there can also be a reverberation artifact which can mimic the flap. So the image is this image, mid-esophageal aortic valve long axis view, shows a reverberation artifact which can mimic aortic dissection. And the common views which we are supposed to evaluate aortic dissection are mid-esophageal ascending aorta short axis and mid-esophageal ascending aorta long axis view. And for aortic arch, upper esophageal aortic arch long axis and upper esophageal aortic arch short axis view. And for descending aorta short axis and long axis view. So this slide shows you the difference between true and false lumen. Often it is very confusing in intraoperative setting to identify the true and false lumen. So true lumen is usually smaller in size, and it expands during systole, and there is high velocity laminar flow, and there is direct continuity with LVOT, and and on color Doppler it shows early filling, and there is no thrombus usually. And false lumen is usually larger, and there is low swirling flow, and some sec is common, and partial or complete thrombosis is possible, and there is delayed color filling and may show diastolic flow reversal. And these two images show the true and false lumen, and the upper image, the mid-esophageal aortic valve long axis view, shows the intimal flap, and it also there is also marked true lumen and false lumen. As you can see, the true lumen is usually smaller and false lumen is very big. And the second image, the same patient, this is showing descending aorta long axis view at the level of mid-esophageal, and it shows the dissection extending into the descending thoracic aorta, and we can see the true lumen and false lumen here also. So beyond this true lumen, false lumen and flap, we are supposed to assess other problems like the competence of valve. We should assess aortic regurgitation, and the leaflets and root dilatation. And also we should assess myocardial ischemia if there is any coronary artery involvement, and if there is any regional wall motion abnormality present. It all indicates to involvement of coronary arteries, and also some other complications like hemopericardium and if tamponade. All these should be assessed. And also branch vessel extension, the extension of dissection into arch vessels, descending aorta, all these must be evaluated. So coming to the next topic, pericardial diseases. So disease of pericardium can be found in multitude of clinical scenarios, including infectious, rheumatic and oncologic and post-surgical processes. These range from pericardial effusion to tamponade, acute recurrent pericarditis and constrictive pericarditis, pericardial masses and pericardial tumors. Pericardial disease are less common than adults, but it causes high hemodynamic impact. Effusion children are frequently loculated rather than circumferential, and also small pericardial volume can cause rapid tamponade in children. And transthoracic imaging is usually the first line, but TE is superior in ICU or perioperative setting, and also it is critical for mechanism based management. So coming to pericardial effusion, as you can see in the image, there is an anechoic space between visceral and parietal pericardium, and it can also be circumferential or loculated. The best assessed in multiple views like mid-esophageal 4-chamber, bicaval and transgastric short axis view, and posterior collections are better visualized in transesophageal echo than transthoracic echo. And also we should assess the distribution of effusion across the chambers, all cardiac chambers. So this is a table like morphology of effusion, it can be either simple effusion, it can be the simple effusion can be anechoic, free flowing. Complex effusion has many internal echoes, septations, and hemopericardium shows echogenic swirling fluid, and pericardial clot can also be visualized, and fibrin strands, if it is visualized, it suggests any inflammatory or post-operative state. And when effusion evolves into a tamponade, the findings would be RA systolic collapse, which is the earliest sensitive sign, and the most specific sign would be RV early diastolic collapse, and there will be a small underfilled ventricle, and there can be a regional chamber compression in loculated effusion, and also there we can see a swinging heart in large effusions. And on hemodynamic Doppler, features would be mitral inflow respiratory variation greater than 25%, and tricuspid inflow variation greater than 40%, hepatic vein diastolic flow reversal seen in expiration, and reduced LV stroke volume, exaggerated ventricular interdependence, and IVC plethora can also be visualized. And we should remember that in pediatric, small loculated collection can cause severe regional tamponade. So now the views that we are supposed to assess for pericardial effusion is mid-esophageal 4-chamber view and mid-esophageal bicaval. This bicaval view, we can see the RF free wall compression and mid-esophageal RV inflow outflow for anterior collections, transgastric basal short axis view for any circumferential fluid, and descending aorta views for posterior collections. And always we should perform a multiplane sweep of entire pericardium rather than a single view. So in this image we can see a patient displaying a pericardial effusion towards the towards the LV anterior wall. So this is a transgastric mid papillary short axis view. So next comes constrictive pericarditis. The constrictive pericarditis in children could be post-surgical, post-infectious, which is most commonly TB, and can also be radiation, which is radiation or idiopathic, which is very rare. And in constrictive pericarditis, we can see a non-compliant thickened pericardium that limits the diastolic filling, and there can be dissociation between intrathoracic and intracardiac pressure, and marked ventricular interdependence, and and systemic venous congestion is very common. So the goal of TE in constrictive pericarditis is not to just show a thickened pericardium, but to prove a constrictive physiology. In this image you can see during inspiration the right side of heart receives more volume, so but it is limited by the thickened pericardium. So to compensate that, the IVC, the interventricular septum will be shifting towards the left to accommodate the more volume. The opposite occurs during the expiration. So all these we can correlate with echo findings. 2D morphologic features of constrictive pericarditis include pericardial thickening, and calcification may be subtle in children but can be seen. Biatrial enlargement can be seen, normal or small ventricular size, and dilated IVC and hepatic veins, and abnormal septal motion can be visible in transgastric short axis view, and it can also coexist with small pericardial effusion. And the septal shift towards LV during inspiration can produce a septal bounce, and it can be exaggerated with respiration, and it reflects the ventricular interdependence. It can be best seen in transgastric mid short axis view. On Doppler, the mitral inflow respiratory variation can be greater than 25. E wave decreases during inspiration, and in tricuspid inflow respiration variation can be greater than 40%. Opposite respiratory pattern occurs in tricuspid flow compared to mitral. And in hepatic vein Doppler, there can be prominent diastolic expiratory diastolic flow reversal and reduced forward diastolic flow. Next comes annulus reversus, which is a pathognomic sign of constrictive pericarditis. So in normal heart, the lateral mitral annulus moves more. So lateral E prime is greater than septal E prime in tissue Doppler because lateral wall is more free to expand, and rigid pericardium in constrictive pericarditis, that is the lateral LV wall, and longitudinal motion of lateral annulus is reduced, and while the septal motion is preserved or exaggerated. So we can see in constrictive pericarditis septal E prime greater than lateral E prime, which is termed as annulus reversus, and the image depicts the annulus reversus, and and this is one of the most important sign in constrictive pericarditis, which differentiates from restrictive pericarditis. So coming to the last non-congenital topic, cardiac tumors. So it is a rare but clinically significant in children. Majority of cardiac tumors are benign primary tumor and often detected incidentally on echo. The common tumors are rhabdomyoma, fibroma, myxoma, and presentation depends on location rather than size, and may cause obstruction, arrhythmias, or embolism. Echocardiography is usually the first line diagnostic tool. TE provides superior in intraoperative scenarios, and it is also essential for surgical planning and any detecting any residual abnormalities after excision. So also one important point is many tumors, pediatric tumors, may regress spontaneously. Mostly the surgical decision would be because of the mass effects of the tumor. So intraoperative TE objectives in cardiac tumor excision is to confirm the pre-resection anatomy, to guide the surgical approach, to detect any residual tumor after excision, to assess the valve integrity after excision, to evaluate the ventricular function, to identify any new obstruction or regurgitation if present. So morphology of tumor should be assessed. So we should assess the exact chamber of origin, attachment of tumor to any septum or valve or any mitral or tricuspid valves, and also we should assess the size, and if 3D is available, we can also assess the extent and number of lesions, single versus multiple, and the mobility of the tumor, if it is pedunculated or if it is sessile, and also relation to outflow tracts. All these should be assessed. So coming to rhabdomyoma, so it is the most common primary cardiac tumor in infant and children, and also it has a strong association with tuberous sclerosis, often detected in infancy or prenatally. And the morphology, if you see, it can be multiple well circumscribed masses, and it is homogeneous and highly echogenic, and intramyocardial location is common, and predilection for ventricular myocardium, and usually it is non-pedunculated and non-mobile. Here you can see a mid-esophageal bicaval view, and you can see a large right atrial rhabdomyoma, and as you can see, it is located in the junction of RA and SVC, causing obstruction to SVC. So mostly it will be asymptomatic rhabdomyoma, and it can cause RVOT, LVOT obstruction, arrhythmia, and ventricular dysfunction. And one important thing of rhabdomyoma is high rate of spontaneous regression. Surgery is rarely required, and only indication is when it causes obstruction symptoms. Surgery is indicated, and the role of TE is to define the number of the masses and location of the masses, to assess any inflow and outflow obstruction, to evaluate ventricular function, and to follow up if there is a regression on serial echoes. And this is the same tumor on mid-esophageal 4-chamber view. So coming to next tumor, fibroma. It is the second most common tumor in children, and usually a single large mass, and usually intramural within ventricular free wall or septum, and well defined, homogeneous, and highly echogenic. It may contain central calcification, and typically it is non-mobile and non-pedunculated, and the most common location is LV free wall. Arrhythmias are more common, and it can also cause ventricular inflow impairment and ventricular dysfunction. And this image shows fibroma attached to the LV free wall, and this fibroma is very large, circumscribed, and also, as you can see, it is highly echogenic, and it has highly echolucent areas and cystic degeneration or necrosis. So coming to next tumor, myxoma, and this is the most common primary cardiac tumor overall, but less common in children than in adults. And typically the origin is left atrium attached to interatrial septum, and in T we can see a pedunculated mobile heterogeneous mass and with a frond-like surface. It shows a dynamic behavior, often prolapses through the mitral valve in diastole, causing functional mitral stenosis. And major risk is systemic embolization, and hemodynamically it can cause mitral inflow obstruction, and positional symptoms, and can cause syncope. And surgical resection is recommended. Recurrence is uncommon but possible. This image shows you mid-esophageal 4-chamber view, showing a moderate size lobulated left atrial myxoma attached to the left atrial aspect of the interatrial septum, just posterior to the aortic rule. Coming to other cardiac tumors, first we'll see about hemangioma. It's a rare benign vascular tumor. It may arise from myocardium or pericardium. On echo, it is highly heterogeneous and highly vascular mass, and color Doppler can show internal flow. It can also cause arrhythmias or obstruction, and surgical excision is required if it is symptomatic. In this image, you can see the heterogeneous nature of the tumor. So the last tumor is pericardial teratoma. It is most common pericardial tumor in infants. It usually arises near the great vessels aorta or pulmonary artery. It is often associated with large pericardial effusion. On echo, you can see a heterogeneous extracardiac mass. It can cause cardiac compression or tamponade. Early surgical removal is usually required. This is a thoracic apical 4-chamber view showing an extrapericardial mass that is actually compressing the cardiac chamber. So finally, in pediatric non-congenital heart disease, T is not merely diagnostic, it is a dynamic decision-making tool that directly impacts outcome. Thank you.